It used to be that I would use custom abutments on the only, but now I find that we're doing them in the back, particularly if we've got a multi-unit case. That way everything comes back parallel, relatively parallel. The path of draw has already been determined, and then the temporary restorations can be made at the same time. And so we'll look at several cases of that today. So custom versus stock abutments. All right, those are some tapered screw vent case. Tapered screw vent case. Here we determine, diameters and lengths of implants ahead of time. These are stock these are custom abutments from Zimmer, and these things are made to follow the free gingival margins of the edentulous sites. And the advantages are you can design your own emergence profile. You can put the exact margin placement wherever you want, which is going to prevent cement entrapment. You restore this like conventional crown and bridge, which, Ed, for you would be such a good thing for your referral guys. It's like, hey, just take a crown and bridge impression. You don't need these nuts and bolts and snaps and all these devices. You just treat this like normal crown and bridge. And then the lab ought to charge a normal crown and bridge fee. Because if they have an anatomically correct preparation, there should not be a $50 or $100 surcharge on that. People ask me, what do you charge for an implant crown? It's like, same as any other crown. It's a tenth of the work. I mean, it's no work because I'm not numbing them. I'm not grinding the tooth down. I'm not doing all these things, packing cord or whatever. I'm just taking a temporary off, taking an impression, put the temporary back in. So now the crown fee can be more like a regular crown and bridge fee. And the custom abutment fee, I think we charge like $500. It costs us $170. Temporary is another $25 or $30. And I think that's fair. And that's just kind of the way we're doing things. I'm not saying that's the only way to do it. It just works well for us. Since we do this every day, all day long, we're always looking for ways to not rush or shortcuts, but ways to be able to become more efficient. With the goal being, if somebody needs a bunch of this work done, I don't want to have to charge them that. I want to try to figure out a way to bring it down. And look, it's parts and labor. I'm real proud of what I know and what we all know, but it's parts and labor to me. And this is a single mom who needs number 8 replaced, and she's got 2 jobs, and she's got kids in grammar school and all that. I don't want to charge her $4,800 to replace tooth number 8. I just got to figure out a way to get around that. And so, we're going to pull number 8. It's going to be a simple extraction, not a surgical. We'll do an immediate placement. We're not going to graft it and flip a parcel and do all that other crap and bury the implant and then go back and surgically expose it. We're going to put the implant in the day that we take the tooth out. We're going to make a nice provisional restoration that we're going to shape so that the tissue will form a nice emergence or a nice, what's the word I'm thinking for? It makes a nice emergence hole profile. Joel, we drank too much last night. In fact, I was so tired on the way here yesterday. I never do this. I pulled over and took a nap on the interstate. Then I stopped in Morgan City because I got a large fry and a cappuccino. The cappuccino was like, I said, yeah, give me a large. It was like a quart. So that and large fries, it's healthy, huh? I decided I don't like health food. I'm just, it's like 60 years old. We're not, got one foot on a banana peel, another on the coffin. I'm going to start enjoying myself. So large fries and a cappuccino. Felt fantastic after that. There's a free dental lab there in Golden, Colorado. A guy named Chris Scharf. He and I have worked a lot together to try and perfect this thing. And now it's just like a smooth thing. Things just go out in the mail. They were making us pour up our own models and mount them. I said, we ain't doing that anymore. And then we were doing scans with them, and that was working out. But I'm not big on the scanner right now. And so when we can, triple tray impression. A lot of these cases, we have to take full arches with a bite. Just put it in a box, send it off, comes back. It's mounted, custom abutments, nice temporaries. Not doing the final crowns yet. I want to put that abutment in, check everything out, and take a simple impression, put the temporary on, and then it's just a no-brainer after that for me. It's not the only way to do it. We'll talk about screw-in crowns and some other things. Also, Midwest Dental Ceramics, they're in Iowa. Very good lab, does the same stuff. Those are the 2 that we're using. No self-respecting grandfather would give a slide presentation without showing his granddaughter. This is my daughter's kid. I got to go back tonight. I really wanted to stay in New Orleans, but I got to haul around the neighborhood in a wagon, trick or treat. She's not going to know what the hell's going on. She'll be crying the whole time. The nice thing about this is when we're designing a case, you know, they'll send me this image. It's like, look, I don't want the margin to stop right here. I want you to bring it out to here. And so then the lab starts to understand, oh, we want to make the molar almost as wide as a real molar, so that when the dentist makes the crown, the patient's not coming and say, hey man, every time I eat a Big Mac, the stuff's getting caught in there, lettuce and tomatoes and all that kind of stuff is getting caught between my tooth and the adjacent teeth. Well, we can help prevent all of that, make it easier on the general dentist referral guy by getting this right. And I want to make this look like a real tooth that Jerry Sheesh prepped for a crown. That's what I want it to look like. So the lab goes to make the final crown. They don't even have to think. It's like perfect crown prep, make a nice crown, minimize. One of the biggest complaints that we get is food getting caught between these teeth because there's no papilla. And so we've got to make these crowns more box-shaped. Because if you make them elliptical, there's going to be Winston Deal used to say, I want to have enough room in here to drag a cat through. Because from a periodontal standpoint, man, they can get a proxy brush in there and clean it real well, but they're going to hate it. Because every time they eat, they're going to think of you. I paid $4,200. I know. And I thought it was going to last forever. All this stuff. So what they're doing here is this live online case design. I don't do this with them anymore. But when we first started working together, they said, hey, we've got to talk to you about this case. They dial in the computer. They bring the images up. And you can talk about, well, these teeth are tilted. How do you want to make your abutment? It's really slick. It really is slick. So here's an example of a case. This guy used to live next door to me. He had to lose both of these teeth. Immediate placement of AnyRidge implants. Real good initial fixation. I'm going to tell you this. We've been using tapered screw vent for a long, long time, and my immediate placement success is not what it is now because of the change. You know, I just wouldn't get that good of initial fixation all of the time, whereas with this, you get it all the time. And I'm not saying we never have failures, but they're really pretty rare. They really are. And so these are the custom abutments back from Midwest Dental Ceramics. These things are actually dentin colored. They're not white like those. It's a shaded zirconium, I guess. And these are the temporaries that they made for the case. So now I'm done. This guy goes back to Sam Moss, and Sam's going to make his final crowns. But look how easy it's going to be for him to restore this. Kind of same thing here. It's a friend of ours. It's in New York City, fell down, knocked out number 9. Real picky gal. But custom abutment, veneer preps on these adjacent teeth. This is tapered screw vent, immediate implant placement. You know, and when we're doing this, you know, we've taken the tooth out. I'm going to use a bone spreader right here to develop a site. No flap, because I don't want to cause any kind of recession or papilla blunting or anything like that. And then after we've prepared this to like 3.2 or 3.3 millimeters diameter, we'll put this radiographic indicator in there and go ahead and pack our bone, then pull this out, and then go ahead and place the implant in that spot. And then we'll take a peak abutment and secure it to the implant and add some flowable resin to develop that emergence on the temporary, and then just screw the temporary right back, screw the temporary into place. And here we are, you know, final case, you know, down the road somewhat. I'm going to show some nice stuff, and I'm going to show some bad stuff, because I don't think it's right to stand up here and just say, oh, look how wonderful I am and did this, I did that. Because we have some screw-ups, and I want to make sure that we get through some of these. This is a little girl that had some cantilevered bridges. This is 6 and 7, and then 11 and 10 over here. This is before. This is simulation of what we wanted to try to do. Here we've used, these are tapered screw band implants, custom abutments, and re-prepared these canine teeth. It's just the final restoration. Another case, custom abutments replacing number 8 and 9. Just looking at this, some of the scans that we're seeing with a lot of these immediate placements. In this particular case right here, she had an apical problem. She had an apicectomy, didn't work out. And here's a tapered screw band in place. Custom abutment from Esprit Dental Lab, and we let them go ahead and make the final crown, which is going to be an Emax crown. And most of what we do is Emax. I know that they've got zirconium crowns out there. I just don't know if they're that aesthetic. So Emax seems to be the way to go. It's not perfect. You know, I use a commercial lab just like, you know, and that was the thing. I forgot who was lecturing one day. They said, you realize most of the people that present, they're paying a lab guy $450 to $500 a unit. Mike Malone and I work a lot together. Ballerina is $450 a unit, I think, or something like that. You know, this is like 130 or something like that. So I don't use fancy labs. We don't charge exorbitant fees. Like I said, I just see plain old folks like most of y'all do. But nice result. You know, maybe not quintessence result, but definitely she was impressed, and I like the result as well. This is a lady from Baton Rouge, and she comes in, and she had to have number 11 extracted, and the dentist did a 3-unit cantilever bridge replacing 11. And they made the bridge before the tissue was healed, so she had a huge void behind number 11, and food was getting trapped up there and all this kind of stuff. And she was furious with this guy. And I don't like this guy. I happen to know him, and I don't like him. I'm not going to say who it is. But I had a good chance to throw him under the bus, and I did not. But I thought about it. I'll give you a hint. I'm on the State Board of Dentistry, and we're having some issues with the Louisiana Dental Association. And the issues have been brought on by the fact that some of the people that have been sanctioned are really unhappy with the way they've been treated. And I tend to agree with that. You know, we're professionals. We're not common criminals. You know, if you're being investigated, the investigator needs to treat you with respect, and so do the attorneys that are involved. But there have been some real upset feelings, and it even got to the point where the senator, I think from New Orleans, Senator Martini, is that his name? Is that New Orleans? Yeah. They got this guy hooked into the deal, and they wrote a bill saying, you know, we got to get rid of our investigator, we got to get rid of this lawyer that we have. They want term limits, which I do think is a good idea. I don't know how anybody in their right mind could be on that board for more than 10 years. I mean, it just blows my mind. I've been on it too, and I think dentistry can be a thankless job, but I got news for you. That board can really be a thankless job. And what I'm happy to report is I really do think that the people on the board are some of the finest people I know. They're not out to get anybody. I used to think it was that way. But now that I'm part of it, I can tell you it's just the opposite of that. There's some things that happen, and you know, we have rules and regulations and advertising and spore testing and all these things that we're supposed to be doing. And if we don't follow the rules, and I've been sanctioned 3 times after I got on the board, because you know we didn't have I don't know, we had some new girl and she didn't spore test for like 2 months, so I got cited. And then when I introduced Danny into the practice, I just put adult comprehensive dentistry. I forgot to put general dentistry in the damn ad. So I got another letter. And then I got another letter. What was the other? Oh, yeah. The other letter was, I use IV sedation. You have to have 8 hours of CE every 5 years. I didn't even know that, you know. So one day at the meeting, I said, is this some kind of initiation deal where you're the new guy on the board and you get sanctioned like once a week? I had 3 sanctions. So, you know, it is intimidating. It's like we were saying one day, if you get a letter from the board, you don't just throw it on your desk and say, well, I'm going to go check this hygiene patient. I'll see what that's all about later. You know, it's scary because the board does control your licensure, but I want you to understand, and I mean this sincerely, they're not out to get anybody. We're just trying to do our job. There have been some upset feelings, and then all of a sudden the LDA says, y'all need to move your office to Baton Rouge. So that's where the big controversy is right now. And we don't want to move to Baton Rouge because we have 12 employees in New Orleans with 44 years of experience. They do a good job. They're not perfect any more than the people in your front office are, but they really do a good job. And our director is a dentist. His name is Art Hickman. He's a dentist and he's a lawyer, and he really does a good job. And if we have to move to Baton Rouge, we lose all those employees, and we won't have a board. And I'll quit because I don't have time to go hire people and do all these things. So that's what the controversy is about. And this guy is one of the people that wants us to move to Baton Rouge, but I ain't going to say who it is. Anyway, so having a little tangent. So anyway, we place an implant in this site, okay? And here's our custom abutment. And we're high up here because when this tooth was taken out, there's no bone grafting done. So, or immediate placement would have definitely prevented that. But she was real happy. For some reason, this bridge was driving her crazy. And she's one of these last magnolias, real high maintenance. She feels things that nobody else can feel. She felt like these two splinted teeth with the cantilever had her mouth in a bind. You know. And the longer that I practice, the harder it is for my eyes just to not glaze over when people start saying stuff like that. So I said, look, I think state-of-the-art dentistry is we keep individual teeth. We don't tie anything together. So custom abutment from Esprit Dental Lab, Crown and Bridge done, Acadian Dental Lab in Lafayette. Nice result. Patient's happy. I don't know. I think I talked her out of going strangle the dentist that had done the cantilever bridge before. And I don't mean to throw anybody under the bus. It's just that if you think about it, if you had to have a canine removed, would you let somebody grind down your two bicuspids and make a cantilever bridge? It's just not a good idea. Cantilevers are a bad idea. And I've done enough of them to tell you firsthand they're a real bad idea. Because sooner or later, the members of the team are going to give out, and then we wind up losing something. We'll talk about connective tissue grafting. I don't know how well that's showing up on this screen, but this is a patient that has metal abutments and all ceramic crowns. And so she comes to see us. A friend of mine had done the case. She comes to see us. She says, I can't stand my smile. All this gray is showing through. And, you go back to that thing, an ounce of prevention is worth a pound of cure. Should have done some connective tissue grafting when the implants were placed. Should have used some all-ceramic abutments. It really would have given a much nicer result. Now she's got to have some other stuff done. We also have used a titanium abutment opaquer. It's called white metal opaquers from Blue Sky Bio. It's pretty slick. Because every now and then you run into a situation where the lab says, hey, we can't make a zirconium abutment. There's not enough room, or you angled out too far, and so we can't put the zirconium on a tie base and make it work. So in those situations, you can have a titanium abutment made, and then you can get this white opaquer and paint this, and it really works out well. I mean, it totally blocks it out. We do something called anodizing our abutments, which creates a golden color, and the gold reflects light through the tissue much better than silver titanium does, because this tends to look gray. And the guy that made the machine for me is a friend of mine named Norm Barbon. He has a website called chemistry4dentistry.com. And I think the unit maybe costs a couple $100. But this is all it is. You got this guy, he really is a genius. I said, Norm, we need to figure out a way to gold plate abutments. He goes, oh, you can't gold plate them because it's non-ferrous metal or whatever. He goes, I'm going to build an anodizer, I'll mail it to you. So he mails me this thing, and what you do is you set this on 62 volts, and in here we have mule team borax, which is some kind of electrolytic thing, and when you dip these things in there and you hit with electrode, and they turn gold in like 2 seconds. And so it just looks nice. Here's what you get back from the lab. We just throw these in the little thing, hit it with the electrode, this little electrode right here, and it turns them gold instantly. So once again, what comes back to the lab for me is I send them this soft tissue model, mounted sometimes, and then this is what they send back along with the temporary. So when we deliver this case, literally, I can go in the room and the dental assistant's already put the abutments in. And she's already put the temporaries on and adjusted the bite and all that. And I just go in the room, look at everything, torque in all my abutments. We pack Teflon tape into all the access holes, and I use a flowable composite. And then if it's my case, we'll go ahead and take our final crown and bridge impressions. If it's somebody else's case, we'll put these temporaries on and send them back. And so when it's time for the restorative dentist to take his or her final impressions, this is just easy. Because everything's parallel, everything's lined up, you have the right amount of reduction, nice temporaries so the patient's functioning and not complaining about, you've got coping cemented on there that are coming off and now the gums are growing over and all this stuff. These things fit on these abutments perfectly. Same thing here. We deliver this case. We've got a whole set of temporaries that the lab made. I'm going to go ahead and screw all these into place. We're going to go ahead and cement this into place and test drive these temporaries and make sure they like the interincisal relationship, the midline, speech, all those things. And if they like this, and this is working out real well, then what we'll do is make a copy of this and put it on the dye model and then send this off to the lab and say, look, just make it just like this. Just copy that. And so it's a way of kind of simplifying what looks like, not in your skill set, but it really is. I mean, it really is. It's just a simpler way of getting from A to Z. You look in these journals, they screwing in Durley, verification jigs, and all this stuff. We're just going back to plain old crown and bridge, And just imagine that these are teeth that have been prepped for crowns, and you're going to make a full arch impression, and you're going to make some sort of fixed cementable prosthesis over this. And so you take a lady like this, Ms. Heinberg's a patient at Sam Moss's. She comes in, we take all these teeth out, put all these implants in, put her in immediate dentures. She immediately looks so much better. Midstream decides she wants to have fixed instead of removable. So here are our custom abutments. Here's a final case on the upper. That's what you start off with before. We'll talk about all on 4. This was supposed to be an overdenture, but she changed her mind and said she wanted fixed. That's why we only have 4 down here. But I like to put 30, 28, 27, 22, 21, 19. 3-unit bridge, 6-unit bridge, 3-unit bridge. For a bunch of reasons. And one of them is, if you do all of this, and what you'll notice here is, these are stress breakers right here. So this really is independent of this. So if they get bone loss around this tooth one day, we can take this bridge out. Okay, that's a keyway right there and a keyway right there. So it's not a roundhouse. But to make an all-on-4 that screws into 4 implants, something's going to happen to these one day in a lot of patients. Maybe not this patient, but when it does happen, all of a sudden, you bought a car and you want to work on the engine. And is that Kramer? Hey, buddy, how you doing? You got a Cayman. What do you have, a Cayman, Porsche? Got a Cayman, you want to work on the engine, but you can't get to it, Somebody welded the hood shut. We've got to think about serviceability. I mean, it's a shame because when a lot of these cases are planned, nobody's looking at down the road, And if you move every 5 years like Mike Schuster used to do, you don't really have to worry about getting in trouble because you just keep moving. So here's our final case. All custom abutments, all parallel. Just not really a difficult case to restore. At the same time, as I said before, my practice is a lot like a lot of yours. We don't just do implants. This guy comes in, he's a train wreck. He can't afford this, he can't afford that. So we looked at the idea as well. Let's hang on to these teeth, put some gold copings over them, make them a maxillary partial denture. Here are the copings in the front. We hung onto these teeth. Here's the partial in place. And so just regular old conventional dentistry. We do a lot of that too. It's just not all implant driven. But here are AnyRidge implants in the posterior mandible on each side. Here are our custom abutments. I'm sorry, I don't know what that must. Yeah, that's just these are the implant analogs in the model. Comes back from the lab. These go right into place in the mouth, and here are the temporaries. And so I'm going to send her back to our dentist. All he's got to do is take these off, take his full lower arch impression, and then put the temporaries back on. Now the margins are all protected because the temporaries fit perfect. And the neat thing is, you're not having to make these. We used to make our own. It just took a huge amount of time. and like I said, now we just have the lab do them. I showed you this case already. Custom abutments in the anterior area. You want to take a, where's Joel?
It's 15 minutes. I got my,
Oh, 15? Oh, okay. Okay, good. Good. I'll show you this case later. Let's see. This is Kenny Sherman here? Ken Sherman. No? His name is on the list. This is his best friend, Clyde Rougeau. He was in our class. Clyde's 68 years old. We call him Pop because he was the oldest guy in the class. But he's going through some of the things I'm going through. He had lost his tooth, had to lose his tooth down here. So here's the AnyRidge, and we'll talk a lot about this today because this is a system where we can do immediate molar placement, which is a kind of a daunting task. We tried immediate placements with other systems with mixed results, sometimes real good results, sometimes not too good. And when you get the not too good result, it's hard to fix the not too good result. So what we do now is, if we're taking a molar out, we use this implant. We'll use fusion bone binder, freeze-dried bone to graft. We place a cytoplast Teflon membrane over the site, and then we suture over that. And you don't have to drag the tissue edges together. You get epithelialization underneath the membrane. And I'll show a bunch of that in a little while. But this case, I just wanted to let you see what was going on. This tooth had been gone, so we left the healing collar in. Here, this is going to be submerged, and then this is the upper bicuspid. These are crowns that were made by Midwest. These are zirconium crowns. The nice thing about these is you don't have that metal channel that shows through. So these things screwed right into place, real good contact. You can't break them with a hammer. Okay? And here they are in the mouth. This is covered with flowable composite. And this right here. Oh, I'm sorry. And right there. So it's another variation on the theme where you've got a zirconium abutment on a tie base and you just screw the thing right into place. It's pretty slick. Pretty slick. Any questions? Yeah.
You were talking your immediate placements, you do the customized screw-in piece. But then you show your implant that's sat in there, and then you come back, you take your impression, and you get the custom abutment made, and you put the temper and you send it back to your dentist.
Right.
None of them are giving you problems. I find that on those anteriors, even as an implant that I let heal for 4 months, I still come back and make a temporary peak and really don't leave them for another couple months. Another extensive treatment.
So that you're talking about in terms of recession after? Okay. I've had some cases where I'd see them 4 or 5 years later, and they're showing a little white line. You know, and that's why some people are advocating, why not use Emax over a tie base? You know, and that way if they do get some recession, you can't even tell. You know, it's Emax crown, then an Emax base. But I've seen some where, you know, the gum has receded. The thought is, and this is what Dennis Tarnow says, if you're able to take the tooth out without laying a flap, then you're probably not going to get any recession. You know what I'm saying? But if you lay a flap, then there's some guesswork that goes into it.
I just find just if you have the implant in and you have a healing abutment,
Right.
that's not the same as having, you know, the tooth in there. So I just find
I don't like to use healing abutments. I like to put in a temporary that day.
okay, but I'm talking about your cases that you don't. That's what I'm asking.
Right. It seems like most of the ones in the anterior we do. And then if we don't put a tooth on it, then we can create a custom temporary abutment, you know, instead of a standardized one that comes out of a box. I don't know if I'm answering your question real well.
No, you are. Customized.
Yeah. And we had this guy from Esprit Dental Lab. I mean, the peak abutments are $50 a piece from Zimmer. What are yours, 60 or 50 or something? 50? And they're real big, and you got to grind them down. And I just got this guy at Esprit Dental Lab to make me like 250 peak abutments. And he makes them in volume, so it's like $10 a piece. You know, and they're all, and we design them on them thin and with a flat side and all that kind of stuff. And so all of a sudden, using these peak abutments is really handy. I'm going to show you, let's see, I'll show you an example of what I'm talking about, if I can find it. Yeah, here we go. I'm going to talk about provisionalization right after our break. But just to give you an idea how we're using these peak abutments, this is a girl who we're in the process of treating right now. She had an implant done years ago. She kind of fell apart, kind of drug abuse, methadone, Adderall, all that stuff. Do y'all see much of that here? This Adderall thing is out of control. It really is. I've had a number of patients that are under the age of 40 that had to have all their teeth crowned or they lost a bunch of teeth, and they have no clue that it's got anything to do with Adderall. I mean, not a clue. And it's scary. I had the daughter of a dentist was in the office yesterday. The dentist is from Ville Platte. He practices with Kirk Swallow, and he brings his daughter in. She's 52 years old. She's got decay on the incisal edges of her centrals, you know, and 2's got to go, 15's got to go, 30's got to go, and just all this stuff. This is a daughter of a dentist. So we were talking. So you have any problems with dry mouth? Oh, yeah. Mouth's dry all the time. I said, what do you take? She said, well, I take Adderall. She goes, if I can't take it, I can't go to work. I mean, it's just that's the way it is. I said, well, fine. You can take it, but you can't drink Coke all day long also, which she does because her mouth's dry. And I said, this is a perfect storm. I said, this is good for business. I mean, You know, that thing about we're going to eradicate decay with a vaccination, all that shit that my daddy was telling me about when I was a kid, that ain't going to happen. I laugh with Don Harris, who's almost 10 years older than I am, every day about the decay problem is completely out of control now. And you know, after age 50, everybody's taking medicine, and you know, over 200 medications prescribed by physicians cause xerostomia, and it was just unbelievable the amount of dental disease that we're seeing out there, you know, and I don't, at least in our generation, I don't see dentistry slowing down much. I really don't. And then we've got a new disease, peri-implantitis, so, you know, business is good. This is a case where we took out all the teeth. We're going to do an immediate provisional on the bottom. So we've got in 6 AnyRidge implants. This is a putty matrix that's made over a diagnostic wax-up. After we've placed the implants, we put in the impression transfers, took an AccuGel impression, which is a real accurate alginate, poured this up in blue mousse. That way we've got a rubber model in 90 seconds. So we've gone from impression to model in a couple minutes. And what we're going to do now is we're going to unscrew these impression transfers. We're going to screw in these peak abutments that I told you that Esprit Dental Rep makes for us. So, Hunter, you see how small these are? You know, they're real thin. And then we're going to go ahead and cover these holes up. Then we're going to take the matrix that was made from the diagnostic wax up, snap it on the model, drill some holes, and then we're going to inject acrylic into this thing and throw it in a pressure pot, let it set up, and then drill access through these guys, and then go back and then and screw this into the mouth. But before we do that, we insert these peak abutments back in, and then we're going to take acrylic and create this emergence on every one of these things. Okay? So this is looking at the occlusal. This is looking at the bottom of it. This would be like teeth in an hour, but it takes more than an hour, and it's a lot less costly because this is something that we can do in the office. And this is what we wind up with. Okay? So we've got our emergence profile developed. This is a 3 millimeter deal from the implant interface to there. It's 3 millimeters. So we're going to go ahead and do all this stuff and come back and go to the mouth with it, put that in the same day the implants are placed. And I have failures in practice. I've never had a failure doing this on a single case. I've had a case where we just replaced number 7, and at 6 weeks there's no bone around it, and there's no rhyme or reason. And it's never, you know, you see these patients that are absolute pigs. They don't take care of themselves. They smoke. You know, they don't brush. And you take out a bunch of teeth and put in 8 or 10 implants, and they don't have a problem anywhere. And then you get somebody who's healthy. You put 1 implant in, and it gets infected. There's no rhyme or reason to it. So I've had good success. As long as you have cross-arch stabilization with implants that get good initial fixation, you know, I feel real confident doing this. Then what we're going to do is we're going to send this off to the lab, have our custom abutments made, use the same wax up, make a new set of temporaries, put our abutments in, and then after this is all polished up, this is going to go in the mouth. So if you see what we've done is we've gone from immediate implants with immediate temporaries, peak abutments, let her heal, get her back in, unscrew all that, take your final impression, that goes to the lab, then make a custom abutments, new set of temporaries, and so we're just going to deliver that, and it's a way of simplifying things. So we break now? No. Okay. Just thought I'd ask. All right. I'll show you a little bit about stents. Like I said, we don't do any guide. I do a little bit of guided surgery, but not very much. This is a drill press from Harbor Freight. I think it costs $60. If it was a dental drill press, it'd be about $3,000. Okay, and all it is a straight drill press. This is comes from a surveyor. So the lower member of the surveyor, which articulates so that you can line your model up. And so we'll do something like we're replacing these 3 teeth with implants. Take a triple tray impression. Dental assistant pours it up, and then I'll mark on the model, you know, the angulations of the adjacent teeth and where this implant needs to go, or where the guide pin needs to be. Do the same thing here, and then we'll go ahead and put this thing back on the drill press, angulate the model to where we want to be parallel to this tooth, and so our drill is going to go into the model parallel to that tooth. Okay. So all we're doing right now is we're just drilling holes in the model, just like we would do in the mouth, but you can see a lot better, you know, outside of the mouth of the model. Measure twice, cut once. So we'll go ahead and do this, drill my holes, and then these are tubes And I'll give you a link to the website where all this information is if you're interested in learning more about this. But these are titanium tubes that are 1.8 millimeters in diameter. The internal diameter, I think, is like 1.7. This fits right in this hole, okay? And so we're going to go ahead and insert those into the model. And then the next thing we're going to do is we're going to pull them out of the model, do a suck down over both of these models, okay? We use a little bit of modern foil so that the suck down doesn't stick to this too readily. And also visible light cured block out material in the embrasures, just like you would use for a bleaching tray. Go ahead and do the suck down, and the dental assistant will go ahead and cut all this stuff out. She's an Almor thing we use to, that soft liming trimmer. It's a hot knife. You can heat up a knife in a Bunsen burner. And just go ahead and cut this out. And then what we'll do is we'll go back and place it on the model, punch a little hole, drop this into place, sandblast the shank, and then put a little bit of cold cure resin around there, and then you've got a good guide. And the only time that I've spent with the model is I've just traced out where it's going to be, marked it, and drilled my hole, and then put it back in the case pan, and she does the rest. Do we do this all day long? No. But when I have a case where we're trying to place 2 implants in a spot like that, I want to do this ahead of time. Because invariably, you get too far away from the bicuspid, or you get too close to the molar, or worst case scenarios, you put both implants and they're both almost touching each other. And that's a bad, that can cause a lot of problems later on. So we do a lot of these. We use quick set, rapid setting acrylic because it sets up real fast. And all we're doing is powder liquiding some acrylic around these shafts. And then we're going to cut these things off, make sure there are no metal burrs in there, put it in cold sterile solution. And then the day of the surgery, we'll go ahead and prior to sterilizing these, we'll cut a window out so you can see where the burr is coming into contact with the bone. And it really makes it nice because all we're going to do is snap this thing into place, drill a pilot hole, throw it in the trash. Put an indicator in there, take an x-ray, make sure that everything's lined up the way that we predetermined it to be. And it's just another way of making stent. You can't have the lab do this. They don't know enough. This is just a simple way to do this. Here's another case. Same thing here. Replacing upper right molar, lower right molar. Here's our little guides. You know, they fit great. The Essex appliance, you just snap them in, take your pilot hole, and we're using a drill from Salvin Dental. It's 1.6 millimeters in diameter. So you're making a little bitty commitment. And then you put a little drill in there and take a PA and make sure that you're not going toward the root of the adjacent tooth, or that you're not too close together, or that all of the predeterminations that you made on the surveyor with the drill press and all that are accurate. And instead of using the pilot drill that comes with everybody's system, which is 2 millimeters or 2.2, we're making a little tiny commitment. That way, if we have to change course, we hadn't violated the bone too much. Yes, sir? Say that again? Most of the time a flat. Most of the time. And really, only because I just respect attached tissue. And it's like, you know, to make an incision and move the buccal tissue out of the way, it just doesn't take any time. You know, yeah, if they got a real wide ridge and a bunch of attached tissue, I just put that thing and just drill right through it, you know, and take a tissue punch and then take that lop off and just go right through it. It's nice. There are no stitches, no swelling. They think you're the greatest thing in the world, you know. So we can get away with it. Yeah, I do like to do that. But in a lot of cases, they've been missing the tooth for a while. It wasn't grafted at the time of extraction. So you don't want to wind up with no attached tissue on the buccal, or minimal. What I'm saying is, if you have a lot of attached tissue, by all means, use a punch. But make sure that you have enough before you lose that. You know what I'm saying? And that's why guided surgery is kind of silly. Because let's say you're replacing somebody's maxillary lateral incisors, and you put the guide in, it's like, well, we're not going to lay a flap. Well, now you're drilling through the tissue, and you're thinning out that buccal tissue on a lateral incisor. Man, that can spell nothing but aesthetic problems later on. So, you know, the longer that I do this, and I know Ed feels the same way, I mean, attached tissue is essential. And so I don't want to ever do anything to compromise it, you know. In fact, you know, and I'll show some CT graft and stuff today. You know, it's a bummer when somebody comes back after 5 or 6 years and says, look, it looks gray up there. And it's like, well, you know what? We should have done a connective tissue graft back then. Now I'm going to do it for free. I'm going to do it for a reduced cost. And had I just addressed the problem back then, we wouldn't be dealing with, you know, an aesthetic situation. You good? Break? Break? Okay. We're going to take a break. What? You got it? All right, good. We're going to change computers again.